abnormalities to detect, because outflow tract abnormalities do not occur in one plane. Four-chamber view abnormalities often are in one plane. Outflow tract abnormalities may be a little more complicated. So you see here this heart. Any of these outflow tract abnormalities can be in this heart. It's possible for this heart to have any of these, and we really can't tell from this view. We need to look much more carefully, and as you know, we need to optimize the image, and we need to optimize the angle, especially for outflow tract abnormalities, but for the fourth chamber as well. So I want to make sure you all probably understand why outflow tract abnormalities are so important. If you look at babies, infants with major forms of heart disease, outflow tract abnormalities or lesions are more likely than four-chamber view abnormalities to require early intervention. And why is that? The answer is fairly simple. It's that outflow tract abnormalities tend to be ductal-dependent lesions, and vice versa. Ductal-dependent lesions tend to be outflow tract abnormalities. So very important to pick up outflow tract abnormalities so that those babies can be delivered at the right place, because those are the babies who will require early intervention. So you all remember this view, my favorite view, with the perpendicular to the septum, with the left ventricle on the bottom, right ventricle on the top, so we see the outflow coming off the left ventricle and the aortic valve opening and closing. And then the outflow tract from the right will come up from the top. That's why it's better to have the LV on the bottom than the RV on the top. If you have it the other way around, it's harder to see the outflow tracts. So let's start with the aortic stenosis. This is relevant to the nice discussion Dr. Dock and Dr. Seam talked about fetal cardiac interventions for aortic stenosis to help prevent the development of hypoplastic left heart syndrome. Not all fetuses with aortic stenosis will go on to develop hypoplastic left heart syndrome. Even many fetuses with severe aortic stenosis do not develop hypoplastic left heart. The key is to know ahead of time how they will progress. But it all starts with identifying the aortic valve abnormality. In that case I showed you this morning that was missed, the aortic valve was not very well seen. The image was not, we saw the left ventricular outflow tract, but it was not optimized. The angle wasn't appropriate, and you could barely see the aortic valve. It wasn't zoomed up. So always look at the aortic valve in every single fetus, including screening as well as fetal echo. Look at the aortic valve very carefully and the pulmonary valve very carefully, just like you look at the mitral and tricuspid valve. So here, this is an abnormal aortic valve. And the more you look at the aortic valve in fetus after fetus after fetus, the better you'll be able to know what's normal and what's not. This is an abnormal valve that's thick, it's not symmetric, and it does not disappear during systole. And if we put color on it, it probably would have regurgitation. So this is many fetuses, if not most, who have valvular aortic stenosis. It begins by being a bicuspid valve that then may progress to become aortic stenosis, or may stay as a bicuspid aortic valve with no stenosis and no regurgitation. It may stay that way for many years. But here on the left, you can see a normal tri-leaflet aortic valve, and what happens is two of the cusps fuse early on, so it's functionally two cusps, or bicuspid, instead of three. So here you can see it opening up like a fish mouth, right here. So here's normal on the left, looks like a Mercedes sign. This is on a short axis view that it's not easy to get this view, but if you can try to open up a Mercedes sign, and here's a bicuspid aortic valve on the right. You can see the difference, yeah? So here's other views. Here's bicuspid in a short axis. Here's bicuspid aortic valve in a long axis. Here's the mitral valve, here's the aortic valve. You can see the leaflets are thick. They don't open up well and they don't disappear. And you can see over here, this is what is this? A dilated coronary sinus that goes along with aortic stenosis and coarctation. And here, over here, you can also see this valve is not symmetric. It's a little thick. It's a bicuspid valve, mild aortic stenosis. Sometimes the aortic valve is normal, but it looks bicuspid because you're not getting a good image. But that just comes with practice. So always just practice to see the aortic valve as best as you can. Here's the same view I showed you earlier on the right, but on the left, this is a case of severe aortic stenosis. The valve is very hard to see. It doesn't disappear. This is very thick. And this is early on. This was around 17 weeks or so. This baby is at high risk for developing hypoplastic left heart syndrome, but some cases do not. So here's with severe aortic stenosis, there's going to be obstruction to flow into the aorta. So you'll see retrograde flow in the aortic arch. Then you can see on a sagittal view, this red, or on a three-vessel view, you can see here. So even with severe aortic stenosis, it may not be coarctation, but it may be coarctation as well. But these are other ways that you can see abnormalities that are related to aortic stenosis. A question is that we sort of talked about this morning in terms of fetal cardiac conventions. When do we intervene? What's the best timing? Dr. Steen was talking about that in terms of the optimal timing. But first we want to know which case. Well, this case on the left, is this going to turn into hypoplastic left heart syndrome? Or this case in the middle, or on the bottom? How about this case on the right? The LV is already dilated and it's not squeezing well. This is a case of aortic stenosis that is very likely to develop into hypoplastic left heart syndrome. But there are many factors that we look at that we've been discussing about this morning. Some of it relates to left ventricular size, some of it relates to flow across the foramen, some relates to flow through the aortic arch. Here's a case of aortic stenosis that I saw before birth, then was dilated in Boston, and has retrograde flow, aortic regurg, which is very common. We want to see that after a successful balloon dilation. They pretty much always see aortic regurgitation that goes away during the remainder of the pregnancy. But as was mentioned earlier, this child is over 10 years old and has multiple surgeries after delivery, multiple surgeries for valve, or replacement, or Ross, and then other procedures. So it is important to remember that dilating aortic valve does not make the heart normal. It just helps to prevent the development of hypoplastic left heart. Let's talk about pulmonary valve stenosis. So here on the image is two normal hearts. Here you can see on the left is a normal pulmonary valve. Here's a normal pulmonary valve. Notice how it disappears during systole. It's thin, it's delicate. And if we put color on, there would be no regurgitation, just like there should be no regurgitation with the aortic valve. Here's normal short axis view of the pulmonary valve. And again, always thinking about structures. The views are important just to see the structures. So here you can see the pulmonary valve. It's thin, it's delicate. It disappears during systole. Same thing over here on the right. You can see the pulmonary valve, it's thin and delicate, it disappears. This valve is not normal. Here's a abnormal pulmonary valve that does not move. The excursion is diminished. The valves are thickened and asymmetric, and there's pulmonary regurgitation that we can see with color. And you can see the flow acceleration during systole across the valve, causing the post-stenonic dilation of the main pulmonary artery. So this is a very obvious case of pulmonary stenosis, but it's important to be able to pick up even mild cases because both aortic and pulmonary stenosis can evolve during the pregnancy. and they both can be associated with either genetic abnormalities or other structural abnormalities, such as aortic stenosis, often associated with coarctation, which you don't want to miss that. So whenever you see a bicuspid aortic valve before birth or aortic stenosis, even if the aortic arch looks okay, very important to look at that baby after birth before you send the baby home to make sure there's no coarctation, because it's so difficult to rule out coarctation. And we know aortic stenosis is a risk factor for coarctation. Here's a clue to pulmonary valve stenosis is oftentimes there will be pulmonary regurgitation first. The valve may look normal, and but the valve leaks, and then gradually the valve becomes thickened as well. So always put color on, look for pulmonary regurgitation, look for aortic regurgitation. Of course, a little bit of tricuspid regurgitation is normal, but that's the only valve that you should see any valve regurgitation in utero. Sometimes you'll see a trivial amount of pulmonary regurgitation in valves that end up being normal. But another clue is that if you have significant pulmonary stenosis, that may increase the pressure on the right ventricle, and that afterload may generate an aneurysmal appearance to the foramen ovale because there's less flow going to the right heart, through the right heart. There's more flow going across the foramen left to right, and it could stretch the foramen and give that appearance. So that's pulmonary stenosis, which is quite important as it's very common abnormality, and it's very often, so those of you who scan, which I think all of you scan, know that the pulmonary valve often is the hardest valve to see. Sometimes it's just hidden, the baby's head is extended at the neck, the chin is on the chest, it's very hard sometimes to see the pulmonary valve. It's very easy to see the other valves sometimes, but the pulmonary valve can be very hard, but it's important not to overlook it. So tetralogy of Fallot, of course, is a very important lesion to detect. And I put this picture up here because it's a normal four-chamber view to point out that a tetralogy of Fallot, even though it's a major heart defect, like most outflow tract abnormalities, typically can have a normal four-chamber view. So tetralogy is important because it's the most common form of blue baby or sinus heart disease, one out of 3,500 babies. There's often genetic abnormalities, either Down syndrome, DeGeorge syndrome, other syndromes, Alagille. It's often dependent upon the ductus. If there's significant pulmonary stenosis, then you're ductal dependent. And if you think the baby may be ductal dependent, then of course you want the baby to be delivered at a place where you can start prostaglandin, and ideally where you do not need to transfer the baby after the baby is born. Finally, it's usually missed before birth because it has a normal, it's okay, go for it. It has a normal four-chamber view, so most of the time it's the four-chamber view will be pretty normal, even though you have tetralogy. And that's because we're looking at the inflow portion here. See the crux, mitral valve, tricuspid valve. We're not seeing the outflow, so this is the crux. This is very close to my favorite view, but it's the inlet. So if we look at the outlet, which I showed you earlier today, optimizing the image perpendicular to the septum, the aortic valve overriding big aorta, and you can see the VSD very obvious right here. So that's usually the first clue, the aorta being big or aortic override, clue to the diagnosis of tetralogy, but it's not enough. Here's more views I showed you earlier. Normal on the left, and then abnormal on the right. The arrow just shows that the ascending aorta is quite big, and you can see the override. And the ascending aorta is very important because if the aorta is small, the ascending aorta is small, as I mentioned earlier, that's a sign for coarct. If it's big, it can be a sign for tetralogy. So sometimes you're not sure, and you should always be using color when we're looking at the fetal heart. But here when we're looking, we think there may be an inflow or outflow tract abnormality, rather right here on the left. Then you put color on, and if you look carefully, you can see blue from the right ventricle into the aorta. Do you see that? You see? Blue from the right ventricle into the aorta. And then as you sweep towards the fetal head, you could see the right ventricular tract is different. There's the blue into the aorta, and then you come up, and then you see the right ventricular tract, so they're different. So you, as you're scanning, you go back and forth to see if it's really different or if you're looking at the same flow. And then the next thing to do, of course, with tetralogy of flow, it's very important to look in more detail at what's causing the obstruction to the right ventricular tract and what do the pulmonary arteries look like? Because often with tetralogy, the pulmonary arteries will be small, they may not be confluent, and the pulmonary valve is typically thick, and you often have obstruction beneath the valve. And the short axis view that we use in fetal echo is very useful to look at all those aspects of the fetal heart. Here on the left, you could see the deviated coronal septum deviating anteriorly and rightward into the right ventricular outflow tract. You see that with the pulmonary valve here. If you look at this leftmost image, you can see the aortic valve is much bigger than the pulmonary valve. That should be your first clue that something's abnormal because the pulmonary valve should always be at least as big as the aortic valve of the fetus. In this case, the aortic valve is much bigger. So here in the middle, you can see that there's prograde flow across the pulmonary valve, but if you look carefully, this pulmonary valve is not moving very well. It's very thick, it's not symmetric. So there's some pulmonary valve stenosis. And you could see this coronal septum above the valve. Over here, you could see it without color. You could see that there's going to be some element of subvalvular pulmonary stenosis as well as valvular pulmonary stenosis. And then here's the main pulmonary artery. Some cases of tetralogy of flow have a very small main pulmonary artery, some is very long, some is very big, but you get nice measurements of the valve, annulus, and of the main pulmonary artery because one, in terms of counseling, we like to know, is this a case which will be ductal dependent? Is this a case that the pulmonary valve is going to be needing to be replaced? Or is this a pulmonary valve? In many cases with tetralogy, the pulmonary valve never needs to be replaced, but in many cases you need to replace it, and you can get some clue about that by looking closely at the anatomy. Here's just a schematic. I showed you this before. I like to see the main pulmonary artery trifurcating into the right, left pulmonary arteries and then the ductus arteriosus so that you get those really nice measurements. You can then measure them and get Z-scores and follow with time. And that helps you counsel in terms of how severe form of tetralogy this will be. So here's looking at the branch pulmonary arteries, the right and the left. Right and the left, you can see here the right pulmonary artery is bifurcating. You can see that out in the lung. So you can get nice measurements of the main of the pulmonary valve and the main and the left and the right pulmonary arteries and get Z-scores of all of them to help prognosticate how small are they. Will they require a lot of intervention, surgery? Will they require stenting? And that helps to give the families an idea of how much intervention the baby's going to require. So here's, again, you can look at the branch pulmonary arteries, the right and then the left. Sometimes you could see both of them in one view, but often you need to change the view a little bit, looking just at the right, looking just at the left to get good images. And then you want to see, of course, with color, this red is retrograde flow through the ductus left to right into the pulmonary artery, which when you see retrograde flow through the ductus in conjunction with tetralogy, that is a suggestion this fetus is likely going to be ductal dependent after birth. So you can counsel the family and make plans in terms of delivery plans in conjunction with the perinatologist, with the obstetrician, pediatric cardiologist, neonatologist to make sure the baby's delivered at the right place. And many babies with tetralogy will have right aortic arch. Sometimes that's a clue that there's tetralogy. You could see a right aortic arch here on a 3-vessel view, the U, or you could see it with sagittal imaging back and forth. You can see the aorta and the trachea. And you can see that the aorta is on the right side of the trachea, whereas the pulmonary are on the left. Usually they're both on the left. but with sagittal imaging, you could see that the trachea goes between the aorta and the pulmonary artery, and you could see the nice U sign with the 3-vessel U. Now, the aortic isthmus in a normal fetus should look a little small, like not quite coarctation, but it should be a little small because not a lot of cardiac output goes across the isthmus in fetal life. But with tetralogy of flow, because there's right ventricular tract obstruction, there's a lot more flow that goes across the isthmus, so that this is a typical aortic arch with tetralogy where the isthmus is not narrowed at all. It's nice and big. It's another clue that there's something abnormal. And then there's various forms of tetralogy of flow. Some forms of tetralogy of flow need one surgery when between 6 months and a year, and that's it. They'll have perfectly normal lives. But other forms of tetralogy can be very severe to the point that they need to be listed for transplant, or there's too many surgeries involved. So tetralogy of flow, one subset is tetralogy of flow with pulmonary atresia. If you have tetralogy of flow with pulmonary atresia, you either have blood flow to the lungs through the PDA, like in this case, there's left to right flow through the PDA, in which case that's a good sign. You could have tetralogy of flow with pulmonary atresia with ductal dependent pulmonary blood flow. That has generally well-formed pulmonary arteries, a good prognosis. In contrast, if you have tetralogy of flow with pulmonary atresia, no ductus, but you have these small aortopulmonary collaterals. See these small red vessels coming off various parts of the aorta. You just lower the Nyquist level when you're looking at the aorta. We can look at this afternoon. Lower it and you'll be able to see these coming off. This is not a good sign. It suggests that the pulmonary arteries are so small that the baby is making new aortopulmonary collaterals to supply the lung. And these are going to need multiple surgeries after delivery throughout childhood, and can be very complicated to reestablish full blood flow to the lungs. Another form of tetralogy of flow that also generally can have a poor prognosis, but not always, is tetralogy of flow with absent pulmonary valve. We call it absent pulmonary valve, but that's a bad term because there is a pulmonary valve. It's just very thick, and it causes stenosis and a lot of regurgitation. So it's actually should be called tetralogy of flow with dysplastic regurgitant pulmonary valve, but that's okay. So why are the pulmonary arteries so big? A couple reasons. First, because you have stenosis and regurgitation, a lot of blood going back and forth, back and forth, back and forth, but also usually this lesion, tetralogy of flow with absent pulmonary valve, has no ductus. And because it has no ductus as a pop-off, usually most of the blood coming across the pulmonary valve to the pulmonary artery just goes through the ductus. But these fetuses have no ductus. So it all has to go into the pulmonary artery. So if they get bigger and bigger and bigger, and what happens is they can get so big they can either cause the lungs to fail to develop pulmonary hypoplasia, or they can cause airway obstruction by compressing the trachea. Here you can see the trachea coming down. Right here you can see how it's narrowed. There's the aorta, there's the trachea, very big pulmonary arteries. Same thing over here. See these huge pulmonary arteries can cause obstruction, and some of these babies need to be intubated soon after delivery. Most are fine, but you just have to be prepared. The family should be counseled, and then you should ideally deliver babies with tetralogy of flow absent pulmonary valve at a center where they're prepared to intubate the baby, provide whatever kind of respiratory support might be needed right away, and hopefully the repair of the tetralogy can be put off a little bit further. Some of these babies develop heart failure too. And why is that? Usually tetralogy of flow in the fetus does not cause heart failure. What's the difference here? The difference is because you have pulmonary regurgitation, the right ventricle gets bigger and bigger, and then the tricuspid valve annulus gets bigger and you start to get tricuspid regurgitation, and that's the first step towards hydrops. That's why you don't see that with normal tetralogy, but you can with this. Here's the three vessel view. It's just nice to show you this is a case of tetralogy absent pulmonary valve with a right aortic arch. There's the trachea. A very big pulmonary artery with flow that's turning around in a circle because it goes into the pulmonary arteries and then back. Can't go through a ductus. Okay, so now let's talk about transposition. There's two kinds of transposition. The most common form, which is 10 times more common than the other form, is what we call detransposition. But any form of transposition, remember to keep things simple. What does transposition mean? Transposition means that the left ventricle gives off the aorta, and the left ventricle gives off the pulmonary artery, and the right ventricle gives off the aorta. In a normal heart, left ventricle gives off the aorta, right ventricle gives off the pulmonary artery. Transposition means they're transposed, that the right ventricle gives off the aorta, the left ventricle gives off the pulmonary artery, period. That's the definition of transposition. Detransposition means that that's the only abnormality, that you have atrioventricular alignment concordance. It just means that the right atrium connects to the right ventricle as it should, the left atrium to the left ventricle as it should. So detransposition just means it's isolated transposition without an abnormality of the atria, how they connect to the ventricles. And this is an example of the way transposition looks. The left ventricle getting off the pulmonary artery and the right ventricle getting off the aorta. It's 3 per 10,000 live births. Often can be associated with complex heart disease. Half the time there's a VSD. Sometimes there's aortic and pulmonary stenosis. There can be a restricted PFO or constricted ductus. There can be coronary anomalies that we cannot see before birth, but it's not usually associated with extracardiac abnormalities or chromosomal abnormalities, but of course you need to check. So the best views to detect transposition are not routine. That's the problem. That's why it's so difficult to pick up. If they were routine for screening, then we wouldn't be missing them, but they're not routine. So this you can see on the left, you can see it's transposition, RV giving off the aorta, LV giving off PA, and over here, RV up top giving off the aorta, and the pulmonary artery down here. But the problem is that it's not routine. And the left ventricular outflow tract, this is normal on the left, and this is abnormal on the right, and they look pretty much the same. So if you just look at towards where you think it's the aortic valve coming off, and that's it, you'll miss clues to the diagnosis. So when you do look at the left ventricular outflow tract in a normal fetus, always go further out than just above the valve. When I was taught about transposition, I was told that if the great artery is crossed, then there's no transposition. But that's not true. Here you could see, even with a bad, can you please go back? So even with a bad angle meaning we're parallel, it looks like they're crossing. But this is a fetus return. Now we have a good angle, perpendicular to the septum, and it still looks like they cross. So crossing isn't good enough. But the sweep, I'm trying not to add extra burden to all of us who do screening, but it really, for transposition, I think a sweep is the way to go. A sweep from the 4-chamber LVOT, a transverse sweep from the 4-chamber LVOT, RVOT. That's all you need. But you have to optimize the image, the right angle. You do that, and you'll pick it up. So if you look here on the left, you can see a normal sweep from the 4-chamber to the LVOT, RVOT. See how it looks, see how they cross, go all the way up, all the way down, and it ends in a 3-vessel view. Here on the right, if you follow with the sweep, even though the 3-vessel view actually looks pretty normal, sometimes a 3-vessel view with transposition can look normal. If you follow it though, you can see the artery that comes off the left ventricle goes straight down posteriorly and bifurcates. The one from the right ventricle comes across and then turns over here, like a pulmonary artery would. So I think the key to detecting transition is doing a sweep from the forechamber through the outflow tracts. And bifurcation off the left ventricular outflow tract, as you see on the left, there's no bifurcation. The aorta doesn't bifurcate, but here with transposition coming off the left ventricle is a pulmonary artery bifurcating. That can be helpful, but the most important thing I think is to do a sweep. This is from a maternal fetal medicine doctor who was a junior attending, whom I had asked all the attendings to send me clips when they weren't sure if it was normal or not, and they just sent on my iPhone. And she sent me this clip and said she wasn't sure if it was normal or not. And if you're looking at it, she did a nice sweep. I'm able to see that this is a case of transposition that I can see pretty easily because it's a sweep. If it was just one image through the forechamber, another through the LVOT, another through the RVOT, it's not nearly as helpful as showing the sweep. And then some cases of transposition, as you know, may be so blue after birth that they require an urgent balloon atrial septostomy. So this is something, if you don't know about it ahead of time, the baby may not be born in a center where that can be performed, or you may just take too long to do it, and the baby may suffer brain damage or may not survive. So if there's a big VSD, then the chance of needing an urgent balloon atrial septostomy is very small with a big VSD. But if there's no VSD or small VSD, then it's very difficult to say this baby is not going to need a balloon atrial septostomy. There are things we can look at. This, by the way, this is the balloon being pulled across the PFO after birth. But we can look at a couple of things. We can look at the direction of flow in the ductus. If there's bidirectional flow, that's a risk factor because this fetus may require an early balloon, or you can look at the flap of the foramen and try to guess if it's, and there are certain markers. But the important message is we're not smart enough yet to rule out to know which fetuses will require a balloon and which will not. So any fetus with transposition, unless it's a very, very large VSD, you need to be prepared to do a balloon atrial septostomy soon after birth. So then we'll move to L transposition. This is not nearly as common. D transposition is 10 times more common. This is transposition, which means LV to the, transposition means LV to the PA, RV to the aorta, but what's happened with LTGA is you have atrioventricular alignment discordance, so the right atrium connects with the left ventricle. So that's one outlet, and the left atrium to the right ventricle. So that's atrioventricular alignment discordance plus transposition. So when we say LTGA, we really mean LTGA plus atrioventricular alignment discordance. It's a problem with the terminology that makes things more confusing than they should be. But this type of transposition will have an abnormal forechamber view, whereas the other type does not. So 3 per 100,000 live births, 90% of them at least will have other abnormalities in the heart. Some of them will have dextrocardia. Almost 80% will have VSDs. A lot of them will have tricuspid valve abnormalities like Epstein's. A lot of them will have pulmonary stenosis. Some will have complete heart block or develop complete heart block during pregnancy. And some will have right ventricular hypoplasia. And then usually not associated with extracardiac structural chromosome abnormalities. So any form of transposition is generally not associated unless you have something more complex like heterotaxy. So here's a four-chamber view on the left that's normal. Here's a four-chamber view on the right that's abnormal, because it's not the L transposition per se that you're seeing what's associated with it, which is ventricular inversion and atrioventricular alignment discordance. So the right atrium is aligned with the left ventricle. The ventricles are L looped so that the left ventricle is in front, anterior. We know it's a left ventricle because it's smooth walled and it has a mitral valve. And we know it's a mitral valve because it's more towards the base. The tricuspid valve is more apical. And you can see the left side of the ventricle, which is the right ventricle, is hypoplastic. So these are abnormalities that we commonly see with LTGG, but it's related to the ventricular inversion. Here's another example, normal on the left. Here's the spine on the right image. Anterior is a smooth walled LV. You can see the tricuspid valve and the right ventricle are posterior, and the tricuspid valve is more apical. You can see there's a big VSD. It's a very dysplastic tricuspid valve, and the right ventricle is a little small. These are all classic findings with ventricular inversion. Here's another example, normal on the left, and here's on the right. This is the left atrial appendage right here. This is the left atrium connecting to the right ventricle. This is the right atrium on top connecting to the left ventricle. You notice the left ventricle. Notice the mitral valve inserts much more towards the base. Here's the tricuspid valve, it's much more apical. In the L, you can see how there's RV hypoplasia. Very classic appearance for LTGA, but it's the ventricular inversion component that we're seeing here. Again, the four-chamber view, spine is over here. This is a hypoplastic right ventricle that's posterior, and we have a very dilated left ventricle that's anterior. You notice a mitral valve because there's no attachments to the septum, and you can see the VSD. So now we'll start looking at the outflow tracts. Of course, L transposition is an outflow tract, but L transposition also has those four-chamber view abnormalities. Normals on the left. On the right, you can see an anterior left ventricle. You know it's a left ventricle because it's smooth walled, and you see the mitral valve in continuity with really the pulmonary valve. Mitral pulmonary continuity, that's a function of this being a left ventricle, not a right ventricle. So, and you can start to see the aortic valve very small, coming off a very small right ventricle. So here, just to review on the left, what's the diagnosis here? You can all see, I hope, that this is transposition. But then here on the right, is this transposition? Yes, it is transposition, but there's also posterior malalignment of the coronal septum. We saw that yesterday in some of the fetuses we were looking at, posterior malalignment, but because there's transposition, this is causing subpulmonary stenosis rather than subaortic stenosis, because this is the pulmonary artery. So it's transposition with subvalvular pulmonary stenosis. And finally, truncus arteriosus. I don't have as beautiful images here today as I like, but this is truncus arteriosus is when you have one semilunar valve, and then both the coronaries, the pulmonary artery, and the aorta all come off that single artery coming off above that one semilunar valve. So it's different from, say, pulmonary atresia, where you only have one semilunar valve, but then you have a main pulmonary artery coming off separately. So truncus arteriosus is less common, but it's usually a much more severe lesion with a worse prognosis, usually. Here you can see the flow going away. The big blue is the aorta, and the small blue is the pulmonary artery coming off, and you can see on the left it's coming off soon after the truncal valve. So it's important to look very closely at the valves, and in this case you can see the truncal valve is thickened. There's only one valve, and with color you can see that it leaks. It's very typical for these truncal valves to leak and to be thickened. And the overall prognosis depends a lot on how badly affected the truncal valve is. It's a very thickened, very abnormal, and that's your only semilunar valve. You have no pulmonary valve. It's a much worse prognosis. The other reason why truncus can carry a very poor prognosis, first of all, I hadn't mentioned, but it often is associated with DeGeorge or other genetic abnormalities. But even without that, this is at 33 weeks. This is a fetus with severe truncal stenosis and regurgitation. So the truncal stenosis is the only way out to the body or to the lungs is through a thickened valve, so the ventricles have to push hard to eject so that takes a lot of oxygen. But there's also regurgitation, and the oxygen comes from the coronary. The coronaries are supplied during diastole at the same time that you have the regurgitation. So you have a high oxygen demand because increased afterload because of the stenosis, but then you have a low oxygen delivery because of diastolic regurgitation. It's not a good combination, and many of these fetus develop significant ventricular dysfunction or heart failure during pregnancy. This is 33 weeks. And here you can see the right ventricle, left ventricle. Here's the tricuspid regurg, the ventricular function, and you can see the ischemia in the papillary muscles of the left ventricle and the right ventricle. This is a fetus who did not survive, developed fluoride hydrops and did not survive. Here you can see at 36 weeks, you can see the right ventricle is barely moving, the very thickened truncal valve. And this is a fetus. There's not much we can do. Whether this is some of these fetuses can have fetal cardiac intervention, it's probably yes, but it's a very small percentage of cases. So the take-home points to review for this presentation: for aortic and pulmonary stenosis, always evaluate the aortic and pulmonary valves really carefully using multiple views, including the long axis perpendicular to the septum and using color Doppler. Remember to use Z-scores if they're indicated. Beware of degraded acoustic windows and be careful how you counsel. And remember that these aortic and pulmonary stenosis can progress throughout gestation and in some cases can affect the way the ventricles grow. For transposition, detransposition will have a normal four-chamber, whereas LTG is abnormal four-chamber because of the atrioventricular alignment discordance. The key for detection, in my opinion, is a sweep from the four-chamber across the left and right ventricular outflow tracts. Remember to evaluate that perpendicular to the septum and optimize the image. And there can be association with other cardiac defects, both in transposition L and D types. And with tetralogy of flow, remember left ventricular long axis, my favorite view, look for aortic override and a dilated aorta could be your first clue, or right aortic arch. Evaluate with 2D perpendicular to septum. The three vessel and sagittal views are both good to evaluate to see if there's a right aortic arch. Short axis is important for looking at the pulmonary valve, subpulmonary area, the main and the branch pulmonary arteries, and look at the ductus arteriosus for which way it's shunting. That could give you a clue which fetus is going to require be ductal dependent. And with truncus, left ventricular long axis, look for override, dilated great artery, evaluate with 2D perpendicular septum. But these fetuses with truncus, it's a high-risk group, especially if the truncal valve is abnormal. High risk for heart failure and high drops and fetal demise. There's usually no ductus arteriosus. There's only a single semilunar valve, and there is commonly genetic abnormalities too. So I think that's it. I hope that was helpful, and sin kan man med.
Yes, thank you so much, Professor Ma. Ngay bây giờ thì chúng ta sẽ